urogynecology. She is a founder member of Female Pelvic Pain Association. And she has been also a representative at the International Advisory Board, International Urogyne Association. And she is a member of various other international bodies. And she's incidentally also the committee member for National Guidelines on Urinary Incontinence of Urological Society of India. So thank you, Dr. Amita, for joining us today in our teaching session. Welcome. We welcome you all. And so now I would request Dr. Dharmendra Jangid to kindly invite the presenter.
Good morning, sir. I request Dr. Gaurav to start his presentation.
Good morning, everyone. Good morning, ma'am. Good morning, sir. Can I start, sir?
Please share your presentation, please.
Yes, sir. Today's topic of discussion in our class is the urinary incontinence in female, in which we will discuss the introduction and evaluation and guidelines for female urinary incontinence. Our moderator is Dr. Dharmendra Jangid, sir. So the urinary incontinence is the involuntary loss of urine that is objectively demonstrable and is socially and hygienic problem to female. The female incontinence usually affect an individual's physical, psychological, or social well-being and is associated with a significant reduction in the quality of life. When we come to the prevalence of the incontinence, the prevalence of urinary incontinence usually increases with the age. For example, in the age group between 15 to 44 years, the incidence of the prevalence of incontinence is approximately 5%, while when the age group is between 45 to 64 years, the prevalence of incontinence reaches up to 10%, and women with age more than 65 years, the prevalence of the incontinence is more than 20%, and it is even higher in women who are institutionalized and may affect up to 40% of those in residential nursing homes. Now come to the type of the urinary incontinence. Urinary incontinence usually divided grossly over the basis of the duration of the symptoms, which is either transient, which usually have the easily reversible cause, or the established urinary incontinence, which is usually not easily reversible causes. The transient urinary incontinence usually remembered as by the mnemonic of diapers, in which we include the delirium or confusional state, infection. In infection, the sensitivity of the bladder mucosa is increased, which lead to the incontinence, atrophic urethritis, and vaginitis, which lead to urinary incontinence. Some pharmaceutical agents like diuretics medication like caffeine, alcohol, which usually lead to the urge incontinence. Some other medications like anticholinergic drugs, alpha agonist, beta agonist, some sedative, antidepressant medications, and antipsychotic medications, which lead to the overflow incontinence. And in some other medication like narcotics, like alpha blocker, like ACE inhibitors, which lead to mixed urinary incontinence. Then some psychological or psychiatric factors also lead to the incontinence, which usually either due to the drugs or the mental status, which lead to the urinary incontinence. And other transient cause include the excessive urine output, which lead to incontinence, and restricted mobility, which usually occur either in the chronically ill patients or in older patients. And other cause include the stool infection, which impacted in the large colon, which decrease the bladder capacity and lead to the urine incontinence. So these all causes are that these all factors lead to the transient urinary incontinence and easily reversible. Then in established urinary incontinence, we grossly divided it into the three parts. First is the stress urinary incontinence. Actually, the stress urinary incontinence is not a diagnosis, it is the sign or a symptoms which patient usually complain. In stress incontinence, the failure of the urethral sphincter to remain closed lead to stress urinary incontinence. It usually occur in small volume and precipitated by the stress maneuver. Stress urinary incontinence, although most common type of incontinence in young women, but it is more common in multiparous women. Then come to the overflow incontinence. Overflow incontinence usually present with the continuous dribbling of the urine. So the overflow incontinence occur due to the distended bladder with high post-void residual volume, and it occur as the continuous small volume leakage like dribbling, and it may or may not be precipitated by the stress maneuver. The overflow incontinence usually divided in two etiology on the basis of etiology in two parts, either due to the impaired detrusor contraction or due to the bladder outlet obstruction. In impaired detrusor contraction, which usually occur as the sign of autonomic neuropathy or spinal cord disease, caudate venous syndrome, or some anticholinergic medication which lead to the impaired detrusor contraction. And the second part is the bladder outlet obstruction, which lead to the chronic urinary retention, and when the bladder capacity bladder unable to void completely, then overflow occur and overflow incontinence occur. Then last one is the urge incontinence. Urge incontinence occur due to the detrusor overactivity. It usually preceded by the abrupt urgency followed by urge incontinence, and it lead to moderate to large leakage of the urine, and usually precipitated by the cold temperature and running water. Apart from these three main type of urinary incontinence, we also have the mixed urinary incontinence, in which mainly both stress incontinence and urge incontinence are involved, and it is the most common type of incontinence found in the female patients. And one other type of incontinence is the functional urinary incontinence, which usually seen in the elderly female patient. The diagram which showing that main type of the incontinence on left side. In first, the overflow incontinence, which usually occur either due to the impaired bladder contraction or due to the outflow obstruction. Then second is the stress incontinence, showing it is usually precipitated by the crying, laughing, or coughing. And then the urge incontinence, which is preceded by the urge of micturition followed by the urge incontinence. And the functional incontinence, which is seen in elderly patient or chronically ill patients. In the diagram in the right side, which is showing normal bladder and bladder of the stress urinary incontinence patient. In normal bladder, usually the sphincter muscles are contracted at strong pelvic floor muscle support, which maintain the urethra in closed state when the intra-abdominal pressure raised. But in a stress urinary incontinence patient, the sphincter muscle either relaxed or the weak pelvic floor muscles, which lead to the urethra partially or completely open, and when pressure from the abdomen increases, then the leakage of urine occurs. Then some other type of the urinary incontinence, which are due to secondary causes like medication, which we have discussed previously. Then urinary tract infection. Then stool infection. Stool infection usually lead to incontinence due to the stool impacted in the large colon, which decreases the bladder capacity, and that lead to incontinence. Then hyperglycemia also cause the incontinence. Usually by the hyperglycemia increase the thrust, which lead to increased water intake and may lead to incontinence. And heart failure, usually the congestive heart failure, for which we take the medication, which lead to the the diuretic medications, which lead to excessive urine production, and which further lead to the urinary incontinence. Then interstitial cystitis also lead to incontinence of urine by increasing in which the sensitivity of the bladder mucosa is high, which lead to the incontinence of the urine. And bladder malignancies, around half of the patient of bladder malignancies usually present with incontinence of urine, either preoperatively or sometime postoperatively, and after chemo or radiotherapy, they complain of urinary incontinence. And then a special type of urinary incontinence is the urodynamic stress incontinence. It is defined as the involuntary leakage of urine during the increased intra-abdominal pressure in the absence of the detrusor contraction. The likely causes of the urodynamic stress incontinence are as follow: the abnormal descent of the bladder neck and proximal urethra, lower intraurethral pressure, and the laxity of suburethral support. Come to the etiology of urodynamic stress incontinence. The damage to the nerve supply of pelvic floor and urethral sphincter, which is usually caused by the childbirth, lead to the progressive change in these structures, resulting in the altered function of urethral sphincter, which lead to incontinence. The second main etiology is the mechanical trauma to the pelvic floor musculature, and endopelvic fascia and ligament occur as a consequence of vaginal delivery. The prolonged second stage of labor, large babies, or instrumented deliveries cause the most damage to the pelvic floor musculature, which lead to the incontinence. In third cause, the menopause and associated tissue atrophy, which also lead to incontinence, and chronic causes like the obesity, the chronic pulmonary obstructive diseases, and raised intra-abdominal pressure, constipation, which also lead to the urodynamic stress incontinence. The congenital causes may be inferred in the urodynamic stress incontinence because nulliparous women suffer from the incontinence may be due to the altered connective tissue, particularly the collagen fibers. Then come to incontinence due to detrusor overactivity. Detrusor overactivity is the involuntary detrusor contraction during the filling phase of cystometry, which may be spontaneous or provoked. The pathophysiology of detrusor overactivity: the largest group of the women which have the detrusor overactivity have the idiopathic variety or neuropathy, which appear to be the most substantiated factor. Incontinence surgery also lead to this, and outflow obstruction and smoking also the causative factor of this. The symptoms in overactive bladder include the urgency, the urge incontinence, frequency, nocturia, stress incontinence, enuresis, and sometimes the voiding difficulties. Then come to overflow incontinence or retention with overflow. It is the insidious failure of bladder for emptying, which lead to chronic retention, and finally, when the normal voiding is ineffective, to overflow incontinence occur. It occur usually due to the lower motor neuron or upper motor neuron lesion, urethral obstruction, or some pharmacological agents. In overflow incontinence, main symptom include poor stream, which usually occur either the impaired bladder contraction or the increased outflow obstruction. Second symptom is incomplete bladder emptying, which lead to higher post-void residue. Then patient complaining of straining to void, which either due to increased outlet obstruction or impaired bladder contraction, and all these lead to overflow stress incontinence. Often there will be recurrent urinary infection because higher post void residue, which lead to recurrent urinary tract infection. Now come to some congenital causes of the urinary incontinence. First is seen in patient with epispadias. In epispadias, there is the faulty midline fusion of the mesoderm, resulting in the widened bladder neck, shortened urethra, and separation of the symphysis pubis, and lead to impaired sphincteric contraction. These patients complain of the stress incontinence, which may not be apparent on laying down, but is noticeable when standing up. And management of these patients are the urethral reconstruction or an artificial urinary sphincter. Then another variety of congenital incontinence in patient with bladder exostrophy patient, in which there is failure of the mesodermal migration with breakdown of the ectoderm and endoderm, resulting in absence of the anterior abdominal wall and anterior bladder wall. So extensive reconstructive surgery is needed to management of these patients. In another variety of congenital incontinence is the ectopic ureter patient, which may be either unilateral or bilateral. Ectopic ureters usually result in incontinence when the opening of ectopic ureter is outside the bladder neck. So the cure of these patients are usually the excision of the ureter with the upper pole of the kidney. Some miscellaneous type of the urinary incontinence are the acute urinary tract infection. So fecal infection in the elderly may lead to temporary urinary incontinence, and urethral diverticulum. In urethral diverticulum may lead to post-micturition dribbling, as urine collects within the diverticulum when we micturate and escape as the patient stand up. Now come to the evaluation of a patient with urinary incontinence. Firstly, an accurate and detailed history and clinical examination is necessary for evaluation of this patient, as there is often a discrepancy between the patient's symptom and the urodynamic findings. The aim of the urodynamic investigation is to provide an accurate diagnosis of the disorder of micturition, and they involve investigation of the lower urinary tract and also the pelvic floor functions for proper investigations. First, the common thing will be excluded, like urine infection, which can produce a variety of urinary symptoms, include the urinary incontinence, for which a nitrate test can suggest the infection, but diagnosis for this is made from a clean catch mid urine specimen. The presence of the raised level of the white blood cells alone suggests an infection, and the test should be repeated. The invasive urodynamic can aggravate the infection, so the test results are invalid and when performed in the presence of infection. So invasive urodynamic testing is usually avoided in the presence of urinary infection. Then second, the most important investigation are the bladder diary. Bladder diary is the simple record of the patient's fluid intake and output. It also includes the episode of urgency and leakage and precipitating event. There is no recommended period for diary keeping, but a suggested practice is 1 week. Provide an assessment of the functional bladder capacity, but bladder diary is also utilized to monitor the conservative treatment like bladder re-education, electrical stimulation, and drug therapy. The diagram showing the bladder diary, which include starting from the left to right, the date and time in which patient mention the date and time of when he start the micturition. In the second row, the urine volume, the exact amount of urine is recorded in ml, and then third column, the exact volume in ml or ounce which he drink. Then leakage of if a patient experience any leakage or accidental leakage, and either note the volume of leakage or rank it 0 to 4 and mention the rank of the leakage, and in the last column the how strong the urge, and the urge also divided in 5 parts, 0 to 4. Then come to PAD test. PAD test, it verify and quantify the urine loss. The International Continence Society PAD test take 1 hour. So the patient wear the pre-wetted sanitary towel and drink 500 ml of water and rest for 15 minutes. After a defined series of defined maneuver like climbing, cuffing, and laughing, the pad is reweighted, and a urine loss of more than 1 gram is considered as the significant urine loss. Nowadays, the popularity of 24-hour and 48-hour PET test is increasing nowadays. Now the quantification of the incontinence based on the PET test at 1 hour reading, if volume of urine loss is less than 10 ml, then it is called as mild incontinence. If it is between 11 ml to 50 ml, then it is called as moderate incontinence, and if it is more than 50 ml, it is considered as the severe incontinence. While in 24-hour PET test, if volume of incontinence is between 4.4 to 20 ml, it is mild. 21 to 74 ml, it is moderate, and more than 75 ml loss in 24 hours is considered as the severe incontinence. Now come to another investigation, is the uroflowmetry. The uroflowmetry, main indication of the uroflowmetry is the complaint of hesitancy and difficult voiding in patient with neuropathy or a past history of urinary retention. It is also indicated prior to bladder, neck surgery or radical pelvic cancer surgeries to exclude the voiding problem that may deteriorate after these surgeries. The normal flow curve is bell-shaped or flow rate less than 15 ml per second on more than one occasion is considered abnormal in female. Now come to the cystometry. It measures the pressure volume relationship of the bladder. It involves the simultaneous abnormal pressure recording in addition to the intravesical pressure monitoring during the bladder filling and voiding. The normal bladder function occurs when the parameters like this: the residual volume less than, normally in normal patient the residual volume is less than 50 ml. The first desire to void occur between the 150 to 200 ml. The normal bladder capacity is around 400 to 600 ml, and the detrusor pressure rises less than 15 centimeter of water during the filling and standing phase, and there is absence of any systolic detrusor contraction during the filling phase, no leakage on cuffing, and a voiding detrusor pressure rise to less than 70 centimeter of water with a peak flow rate of more than 50 ml per second for a volume of more than 150 ml. So come to indication of cystometry. The previous unsuccessful incontinence surgery, patient who have the multiple symptoms like urge incontinence, stress incontinence, and frequency also need systematic evaluation. Some voiding disorders with incontinence need evaluation by the cystometry. Neuropathic bladder also evaluated by the cystometry, and patient who have the prior incontinence surgery needs the systematic evaluation. The detrusor overactivity. In cystometry, the detrusor overactivity is defined as the spontaneous or provoked detrusor contraction occur which the patient cannot suppress. The systolic detrusor overactivity is shown by the phagic contraction during the filling phase. The low compliance detrusor instability is called when the pressure rises during the filling more than 15 centimeter of water and does not settle when the filling phase ceases. Urodynamic stress incontinence is called if leakage occur as a result of cuffing in absence of a rise in the detrusor pressure. Now come to another investigation is the video cystourethroscopy. It is representation of the subtractive cystometry. In video cystourethroscopy, if a radiopaque filling medium is used during the cystometry, the lower urinary tract can be visualized by X-ray screening with an image intensifier. Intravenous urography. Intravenous urography is nowadays not used regularly, but this investigation provides little information about the lower urinary tract and is indicated in case of the hematuria, neuropathic bladder, and suspected uretrovaginal fistulas. And most widely used investigation is the ultrasound, which is used in the urogynecology. This is useful in patient with voiding difficulties, and urethral cyst diverticula can also be examined using this technique. The interpretation of the post-void residual volume with ultrasound is: if PVR is less than 50, then adequate bladder emptying is called. If PVR more than 150 cc, then avoid the bladder relaxing drugs. If PVR more than 200 cc, then patient usually refer to urologist for further evaluation. And if PVR is more than 400 cc, then overflow urinary incontinence is likely to be. MRI. Although MRI produces accurate anatomical picture of the pelvic floor and lower urinary tract, but usually its use is limited to demarcate the compartmental prolapse. Then cystourethroscopy, it is an invasive procedure. There are few indications in women with incontinence, like reduced bladder capacity, a patient who has the history of urgency and frequency with incontinence, patient who has suspected urethrovaginal or vesicovaginal fistula, hematuria or abnormal cytology, and persistent urinary tract infection. And lastly, urethral pressure profiles also done, in which it can be obtained using a catheter tip dual sensor microtransducer measurement of the interluminal pressure along the urethra at rest and under stress condition like coughing, sneezing, and appear to be little clinical value because a large overlap between the control and women with urodynamic stress incontinence. Now, initial management of urinary incontinence in women. The first, the detailed history, clinical examination, and symptom assessment should be done. On the basis of these, either incontinence on physical activity, or incontinence with mixed symptom, or incontinence with urgency or frequency. Then, in clinical assessment of all these, the general assessment done, the urinary diary and symptom scores are assessed and assess the quality of life, and also very important thing is the desire of the woman for the treatment. Then physical examination, in physical examination, abdominal, pelvic, sacral, neurological, and also the estrogen status. If the estrogen status is low, then there is atrophy and which treatment is necessary. Then cuff test to demonstrate the stress incontinence, and urine analysis with or without urine culture, and if infected, treat and then reassess the patient after a certain period. And lastly, assess the post-void residual urine by the abdominal examination like ultrasound. On the basis of these clinical assessment, the incontinence may be stress incontinence, mixed incontinence, and urge incontinence. All of these are firstly managed by the lifestyle intervention, pelvic floor muscle training, bladder training, and after that other physical therapies and devices are used. If failure occurred, then specialized management would be done, and antimuscarinic agents are also given to the patient. If a failure of this treatment, then a specialized treatment to be done. Some complicated incontinence like recurrent incontinence, incontinence associated with the pain, hematuria, recurrent infection, pelvic irradiation, radical pelvic surgeries, and suspected fistulas, and the presence of other abnormalities like significant post-void residue, significant organ prolapse, or pelvic mass, in which specialized management is needed usually. AUA guidelines for the female stress urinary incontinence and treatment algorithm. In initial evaluation of patient desiring to undergo surgical intervention should include the following component. First, the detailed history, then complete physical examination, then demonstration of the stress urinary incontinence, PVR assessment, and urine analysis. Then next come to cystoscopy. It is not done routinely, should not be performed unless there is concern for lower urinary tract abnormality. And then last one is the urodynamic studies. It is usually not done if there is clearly demonstrated stress urinary incontinence. Additional evaluation should be performed in the following scenario: when the definitive diagnosis couldn't be formed, the inability, when we have the inability to demonstrate the stress urinary incontinence, when there is known or suspected neurological lower urinary tract disorder in patient with abnormal urine analysis, and urgency predominant mixed urinary incontinence, patient who have the elevated PVR, high grade pelvic organ prolapse. If stress urinary incontinence not demonstrated with pelvic organ prolapse reduction and the evidence of significant voiding dysfunction, additional evaluation may be performed in the following scenario like concomitant overactive bladder symptom, failure of the prior incontinence surgery, and prior pelvic organ prolapse surgery, after which the definitive management should be done. Thank you, sir.
Thank you, Gaurav. Please unshare your presentation. I would request Dr. Amita. Dr. Amita, please give your comments on the presentation and what else you want to add, or
yes,
please go ahead. Yes.
So thank you so much, sir, for giving me this opportunity. The presentation was very, very good. I will congratulate Dr. Gaurav. He actually have elaborated each and every aspect. I just want to ask something. Can I ask something like
Please, please go ahead.
So Gaurav, I just want to understand which guideline did you follow? Like I can understand the last slide where you have shown you have summarized the American Urological Association and SUFO guideline, but otherwise, it was not mentioned in slides. Which guideline did you follow for your slides? Like which guidelines, or I should say?
Yeah, Gaurav, while making your presentations, which guidelines did you follow? And where did you get these material from? So,
Sir, European Association of Urology guidelines are followed.
Yeah, I think so that these are the latest one. There are a few guidelines or few updation were issued from national NHS also, but few things I just want to comment. Like you mentioned about the types of incontinence, but the continuous one, the fistula was missing. So that's why I was asking that. Yeah, so that was missing. I think that is also an important. You have mentioned everything, but not the fistula. This is also a kind of type of incontinence. You mentioned were secondary causes of incontinence, where actually you have mentioned all the causes already in transient causes of urinary incontinence. But the thing is, I think Dr. Shivam will also agree with me that there was a mention of interstitial cystitis. So actually, we differentiate between interstitial cystitis or overactive bladder, or by the basis of this history only. If there would be incontinence, it can't be interstitial cystitis, or there would be combined presentation of both the diseases, like there would be overactive bladder along with interstitial cystitis. The pure interstitial cystitis will not cause incontinence. So that was the many of the things can just increase the sensitivity when the radiation cystitis. So the incontinence, usually if there is with malignancy, you have to look for fistula also. Because yeah, you are actually presenting incontinence, that's why. I just want to ask a few things. You mentioned about PET test as well. So which PET test is better, 1 hour or 24 hours? And what are the fallacies of the PET test? Why it is not mandatory now? Most of the guidelines omit it.
Ma'am, nowadays 24-hour PET test is usually more used in the practice. Ma'am, good part of this is, ma'am, in 1 hour PET test, usually a very small amount of urine loss usually may be missed, but in 24-hour PET test we can easily measure, because our duration is more, so we can easily evaluate the volume of urine loss.
But what could be the disadvantages of 24 hours as well?
Ma'am, patient have to wear the PET for 24 hours, which lead to the discomfort and odor problems, ma'am.
Exactly, it is not there. Actually, the fallacies is that patient may have perspiration or something which can cause false positive results. So that could be the thing, though. That's why these are the things which can cause fallacies. And also, there could be when there would be false negative results also if the 24 hours the pad will be dried as well. Can you just elaborate on the examination part, because it was missing in the presentation once you presented the symptoms and all, and then you just skipped the examination part and you jumped over the investigation. So cough stress test, these things you just told in that flow chart, but I just want you should elaborate on that part, because it is very, very important, especially in female incontinence, the examination part. So what will you look for during examination part? Explain the cough stress test. These things are important.
Cough stress test.
What is the status of Q-tip test, Boney's test? These things are important. So I just wanted to ask. Yeah.
Okay. Ma'am, cough stress test usually done in a lithotomy position with Usually, ma'am, no.
You will make a lithotomy position for that thing. Okay. No, it's supine or
Yeah.
just pelvic position supine will be okay. Yeah. Please continue.
Yeah. So, Dr. Amita, thank you very much for bringing out those very, very pertinent points, and something very important which Dr. Gaurav has missed. The point that you made in the last was the examination point, which is probably the most important thing that has to be done in any patient, right? So, Gaurav, you missed a very important point in the management evaluation of these patients. So, it's very important to do an examination of these females. And secondly, the point which was brought about by the fistula is, so when you are evaluating incontinence, so definitely there could be a total incontinence also, right? So total incontinence, then you have to differentiate between whether it is a congenital total incontinence or acquired. If it is acquired, Nachiket, please mute yourself. Please mute yourself, Nachiket.
संगीता ये जो किताब
Nachiket,
जिसने लिखी
please
है
mute. Mr. Nimesh, please mute Dr. Nachiket. So that was an important thing because then if it's a total incontinence, then we have to differentiate it between congenital acquired. Acquired will have all those fistula varieties, right? And another point which was brought about is pad test. Yes, we usually do not do pad test nowadays. 1 hour pad test is usually done for patients to differentiate between various types of fistula, right? If it is a uretrovaginal, and all that, the 3 pad test that we usually call. But for differentiating between stress, urge, and all that, and the severity of the disease and quantification of urine loss, definitely a 24-hour pad test is much better. Though the fallacies are there, which Dr. Amita has rightly pointed out. And the one thing which, again, I also was struck about the IC and incontinence. Yes, mostly these IC patients would not be incontinent, and that's a very important differentiating point between overactive bladder syndrome and an IC BPS syndrome. So only in mixed cases, this may be present. Then you talked about overflow incontinence, and you said that upper motor neuron lesion and lower motor neuron lesions can cause retention and overflow incontinence. Usually it is a lower motor neuron lesion which causes overflow incontinence, and upper motor neuron usually cause adductor hyperactivity and may cause hyperreflexia and cause urge incontinence rather than overflow incontinence. And then you had a mention about overflow stress incontinence. I don't think there is something called overflow stress incontinence. So where did you get that term from? I don't know, but that should be, I think, omitted. To add to your presentation, I think regarding the types of incontinence, there are some uncommon variety of incontinence. Like one is a postural incontinence, usually only when the patient is sitting and then standing and she passes urine. This could be a type of severe stress incontinence also, but again, a postural incontinence is also known to occur. Secondly, a giggle incontinence. Patient only when giggles or laughs, there is incontinence. Otherwise, with other physical exertion, she doesn't have this urinary incontinence. That's a special type of. Then a coital incontinence. Some females will have incontinence during coitus. So one is during penetrative part, that is usually kind of a stress incontinence, and the other could be during orgasm. So that is usually an urge incontinence, the pathophysiology. So this is again a very uncommon variety of incontinence that can occur in females. And nocturnal enuresis can also be, you can mention that as a part of when you evaluate urinary incontinence. And this in the etiopathogenesis, you mentioned about all other mechanical trauma and the aging and obesity and multiparity and all that, which can result in incontinence. Again, when there are a lot of research studies have shown that these can have a genetic basis also. So overflow in this overactive bladder, urge incontinence, stress incontinence can have genetic predisposition also. So genetic variants are there which predispose these females to urinary incontinence. So that is also need to be discussed. And the other point which I have a lot of interest in is about the microbiome. So urinary microbiome and vaginal microbiome, if it gets changed, which is called dysbiosis, then there is a preponderance of some of these problems, which includes overactive bladder, urinary incontinence, and even interstitial cystitis bladder pain syndrome. So that's a new area which is being researched into, that the change of microbiome can also result in these problems. So that was from my side. So any faculty or resident, if it has any query to Dr. Amita, she is very kind of specialized in female urology. She is a member of so many international bodies also. She has worked with, and she is a part of our GIPS society also, which works on interstitial cystitis bladder pain syndrome. So if you have any query, please go ahead. Any faculty or resident? I don't see anything in the chat box also. So I would request Dr. Amita to have her last comments, then we will wind up, please.
So thank you so much again, sir, for inviting me for this nice interaction. And I think we have covered all points. Even if you have any query, you can ask me anytime. There is not a kind of restriction of this presentation only. But I think you have covered everything. Examination part you have to elaborate, because if it is for the Viva point of view, you will be asked in examination part. So that was the only last comment. Otherwise, I think you have covered each and everything nicely.
Thank you, Dr. Amita. And I would ask our moderator, Dr. Dharmendra, please give vote of thanks, and then we will wind up.
On the behalf of Urology Department, I especially thank to Amita Madam for sparing valuable time for us and sharing their experience with us. Thank you, Madam. Thank you all.
Thank you. Thank you once again. Thank you, Dr. Amita. Thank you, residents. Thank you, faculty. Thank you, everybody who might have joined us today on the Zoom or YouTube. We have a SMS Urology live stream channel. Our classes are being recorded there, almost more than 100 now. So thank you very much and have a good day.
Thank you, sir. Thank you.
Thank you. Goodbye.